We are excited to welcome you to today's session. My name is Jasmine Burton. I'm the founder of an organization called Wish for Wash Thinks, and I come to this conversation today with nearly a decade of sanitation entrepreneurship, degrees in public health and product design, and as a current MBA student. So this conversation and the intersections of health and business as it relates to sanitation is really resonant with me. So I'm really excited to see where this conversation takes us. And I look forward to unpacking how business approaches in WASH contribute to a healthier and socio-economically empowered communities with our incredible panelists today. So I'd now like to welcome my renowned co-host for our session, Dr. George Kamathi from Amrith Health Africa.
Thank you very much, Jazz, and good morning, good afternoon, colleagues. And I want to reiterate you are most welcome to our session of today. My name is Dr. George Kamathi. I'm the Director Institute of Capacity Development at Amrith Health Africa in Nairobi. Very delighted to be your co-host just today. Just I'm expecting a very interactive session. So I'm so happy to see the numbers that we already getting. I'm expecting to learn a lot from our colleagues from India and from Africa, and to see the link and the opportunities that we have for businesses in the sanitation value chain. So really excited and looking forward. Thank you.
Yes, thank you so much. I'm so thrilled to be co-hosting with you today. And I know as a sanitation entrepreneur myself, operating within the sanitation economy, that there's a clear case for how there's a public cost associated with sanitation, as well as an untapped business opportunity related to WASH and health that can provide both social and economic return. We know that investing in WASH infrastructure, such as toilets and sewers, and bigger systems at large, is a primary prevention method, preventing waterborne water wash diseases before they spread. We also know that there's a growing body of evidence related to WASH and healthcare facilities. There's evidence that shows that over 1 billion people use healthcare facilities that lack basic water services, and over 800 million people use facilities with no toilets. So again, these linkages are becoming very, increasingly more clear. And so I think our panelists today are going to help us dive further into it. I know that there's also a growing body of evidence around entrepreneurship in the sanitation space, and how, the entrepreneurs are operating to help bring more innovation as it relates to these linkages and inclusion around access to sanitation facilities. As a specific case study, I know there's an organization called T-Bus in India where they've retrofitted old municipal buses and turned them into public bathrooms for women that also provides holistic health services where women can breastfeed and have access to menstrual health products, as well as be tested for things like HIV. So again, there's a lot of opportunity to explore sort of these intersections and how business can help kind of drive the sanitation sector forward. So from your experience, Dr. George, how have you seen sanitation health making economic sense for nations and local governments?
A good question, Jazz. And I think we cannot even with the colleagues who are here, we cannot debate the mutuality between health and the economy. But then what makes it even more complicated for populations in India and Africa is that when you think of health and access to healthcare, you cannot avoid thinking of sanitation. Because then when you look at most of the populations, they are 50 plus 60% of ailments that you see in dispensaries, in the health centers, will be linked to poor access to sanitation, which is unacceptable. When actually you go deeper, you find that most of the governments and the whole globe is pushing for USC, and we'll in a few minutes, we'll listen to case studies and what our colleagues in Kenya are doing to push for increased access to healthcare through the USC framework, which is a key pillar for the current government in Kenya. USC is all about leaving no one behind, but you cannot talk leaving no one behind if 60+% of the population doesn't have access to improve sanitation. I mean, that's the biggest question that is in the room today now. And then UAC is also about financial protection, but only 10% of our populations in most of these regions have actually any health insurance cover. And the huge out-of-pocket expenditures that families go through every day. So when you're able to tackle sanitation, when you're able to link it with the businesses, you also give livelihood opportunities to millions of young people. Currently, The unemployment in sub-Saharan Africa is around 30%. And then you have a huge pool of population of young people aged under that 5 years, about 70% of the population. That's a huge pool of energy and creativity, but also huge opportunities within the sanitation value chains, as you put it very well, Jazz. So when you link all those things together, then you see opportunities for us to align with the UHC conversation. And also too, is to appreciate the explosion of information technology that has happened across the globe with huge penetration of mobile technology or mobile phone use and of course, internet. And therefore, our conversation that we're just about to get into of India and how India is using telemedicine, but also linking telemedicine to sanitation and access to sanitation and use of digital tools again in Africa to increase understanding of customer preferences, customer needs, and how even to promote financial inclusion using digital tools. I think that's really exciting. That's what excites me most. That you have a huge challenge here. You have a huge pool of young people who have lots of creativity, lots of interest, and then you have technology. So when you combine the three, I think it's a huge success. But I think that the most important thing for today's conversation is a question around how exactly our teams in India and Africa making this happen. I think that's going to be really interesting. And therefore, I guess just now it's a good time for us to take 2 minutes to watch a short video of Finnish Mondial, and then we get to the actual conversation, if that's okay.
Sounds perfect. Yep, sounds perfect.
Finnish Mondial is a partnership between Waste, AmRef and Aqua for All, and stands for Financial Inclusion, Improved Sanitation and Health. It's a programme working towards safe sanitation for all and is implemented in India, Kenya, Uganda, Ethiopia, Tanzania and Bangladesh. Finnish Mondial ensures people are aware of the need of a safe and durable toilet. They want to buy one, can afford it, and local people can build them. But what does this mean? Women like Anna from Kenya and girls like Juhi from India have a healthy and safe life and can develop themselves. They can work and go to school as they no longer get ill because of water-related diseases. Because of the Finnish programme, sanitation marketeers like Emmy from Tanzania feel they are doing something for their community as they tell people about the importance of a safe and durable toilet, which trained masons like Manu from Ethiopia can build. They now run a successful sanitation business. And farmers like Abdul from Bangladesh use the fecal sludge from the newly built toilets as co-compost for crop production. Therefore, communities are healthier and have climate-resilient food. Finally, financiers like Mr. George from Uganda supply sanitation credit, and local governors like Miss Gamutu from Kenya stimulate sanitation market growth and awareness. By applying a multi-stakeholder approach, the Finnish programme involves the entire sanitation value chain. Over 5.6 million people enjoy the benefits of safe sanitation thanks to the programme. This is only the beginning. Let's create a global sanitation revolution together.
All right, well, a fantastic video sort of encapsulating the essence of this session. And before we transition into our exciting panelists to come, I do want to shine a light on the message that was just dropped in the chat about if you're in the audience and you want to engage, please feel free to send us a message on Pathable. And then also we'll be sharing a graphic recording image at the end that captures the essence of what we've been speaking about. So with that, let's go ahead and transition to some case studies to more explicitly highlight the links between health, sanitation, and business opportunities. I believe Dennis is with us today from AmRef Health Africa, and why don't you go ahead and kick us off with a case study from Kenya about universal health coverage.
Thank you so much. As mentioned, my name is Dennis. I work at AmRef Health Africa. So we're going to talk about our experience implementing the Finnish program and how we link this to universal health coverage. Next slide. The journey towards UHC was rolled out officially in 2018 by the President of Kenya. And this was one of the flagship programs in what was called the Big Four agenda. And the hope was that by 2022, would have everyone in the country be enrolled under the universal health coverage. So it's the UHC is an umbrella that is carried by what we call the National Health Insurance Fund. And at the moment, 50% of Kenyans have this NHIF insurance. Was contributing 330 million. And the hope is that by 2022, would have reached up to $1 billion US dollars. So the issue is that at the moment is that little attention has been paid towards sanitation, even though we know that, for example, diarrhea causes 30% of illnesses in the country. Pneumonia is a big problem for children. And most recently, we have COVID, which is hygiene and sanitation related. As mentioned, at the moment, we have the diamond approach. And the diamond model has 4 components. And I'm just going to mention some of the things that we are doing under some of the pillars of the diamond. For example, we look at our interaction with consumers who are the community. So every day we have what we call the sanitation marketers or community health volunteers who go door to door, convincing and talking to communities to invest their own resources towards sanitation and building a toilet. So what we've done is we've also tailor-made some messages that ensures that we build trust and propagate the information that government, the NHIF, is encouraging people to purchase insurance. So that is one of the things that we're doing. It was mentioned also by Dr. George that every day we work with entrepreneurs and there's local sanitation, local artisans who also ensures that once they build these toilets and the toilets are usable, they're friendly, they don't collapse. That ensures that there is prevention, and that contributes towards elevating the finances that households have to spend when it comes to curing infections. So what we are saying is that the message that we are propagating is that sanitation and hygiene is very, very important and should be prioritized, especially in government financing or by donors. So invest in sanitation and hygiene to ensure that we have quality healthcare services, and ensuring that we don't spend extra money or astronomical figure, for example, like treating COVID. In this country, we've realized that COVID is a very expensive disease. And to ensure that these difficulties are alleviated, we're encouraging governments and donors to invest in sanitation and hygiene. So that's our experience in the country. Thank you so much. Over to you.
All right, thank you so much, Dennis. Really appreciate that. And I think it definitely illuminates the connections that we're looking to further explore today in today's conversation around kind of how improved sanitation really is connected to people's health, and it is connected to a lot of business opportunities in terms of economic sustainability, both locally and globally. So thank you for sharing this case study. So I believe we are transitioning now to our panelists. But before we do that, I would love to hear from any of the audience. If there's any questions, we can make some space for that right now.
Jasmine, I think the audience is warming up.
Okay, awesome.
Okay.
Sounds good.
Okay. Just, I think we have a minute or so for Abhishek, no?
Yes. Let's go ahead and transition to Abhishek. If you want to shine a light on the case study related to India and telemedicine.
Yeah, namaste. I'm Abhishek from Finnish Society, India. And we are doing a pilot on teleconsultation in a state called Odisha. So we started this pilot 2 years back, and due to the hiccups caused because of COVID, so it impacted us a lot, but still, like, we are on the positive direction. And this is basically a pilot with which we are doing, where we are taking in the rural youth as the rural entrepreneurs, and who are conducting the teleconsultations at the doorsteps of the patients, or the beneficiary. And there is a doctor sitting at a remote location from where he is providing his expert opinion. So by this, we basically want to achieve the major objective of the project is to link sanitation with health. So the data generated through this initiative will be basically shared with the health insurance companies to enable them to design primary health related products. So you see, in India, we do not have primary health related insurance products. And the major part of the health expenditure of a rural family is on primary health, so which is not covered. So the basic objective is to get some kind of a data and to establish some kind of a linkage between sanitation and health, which can enable these companies to devise a product which is suitable for the rural audience. And apart from providing them quality health services at their doorstep. And we are also planning in the next phase to link it with lab tests, where like a doorstep sample collection will be done by a company which will be linked with us. And we are also trying to expand it to various microfinance partners who are having their branches at different locations. So we can operate from their branches as well, so that their customer base is also catered through it. And we are also planning to approach various corporates who can at least fund the consultation fee for these people, so that the burden of expenditure on these people gets reduced. So till date, we have done 1,000 plus consultations, despite the COVID challenges. And we hope to take it to a large scale and a sustainable mode. So that is what we are trying in India. So I'll request you all to give us your best wishes and blessings so that we can make it a huge success. Thank you. Namaste.
Thank you very much, Abhishek. Yes, and you have our blessings, Abhishek. Very good presentation there. And this is it. This is not only the future of medicine and access to healthcare. It's actually the current. The question I guess that we'll get into shortly is how exactly are you doing it? What opportunities are you seeing? But perhaps before that is Dr. Avinish, you've been involved. I hope you can hear me. You've been involved with the telemedicine initiative in India for some time now, working closely with the Finnish Mondial team. If you could take a minute or so to share with us your journey of that, the experience that you've seen moving from online to offline, in-person consultation to online consultations, and the link that you are seeing between what you're doing and increase access to sanitation. Dr. Avinish, you can hear me?
Hello. Hello.
Yes, we can hear you, Doctor.
Okay. Good evening, sir. Good evening to the Finnish Society members present online. And it's, sir, when we are, first of all, your question, I am specific to your question only, that what is the difference between an online consultation and an offline consultation? So I should highlight on that, sir. Dr. George, sir.
If you could, and your experience with that, sir, and the opportunities that you see, particularly linking that with the
first of all, as it was my first teleconsultation which I am taking with Finnish Society, it was the first thing. So at the beginning, we were facing a lot of difficulty, like as our project is situated basically in the rural part, in the rural India, and the net connectivity was very poor. So sometimes we have to switch off the consultation. So we are gradually improving. Dr. Abhishek ji is taking every month review. He's trying to improve in every aspect, which I'm giving him the mail. So we are improving. The patients specifically in rural India, we are educating them that you are getting the health at your home, at your doorstep. You need not approach any PHC or CHC. And these consultations are conducted by Finnish Society totally free of cost. So they are agreeing. So it will take some time, sir, as we are in a part of health, and we know that first people need to understand about the health and all that. So after that only they can accept it. So it will take more time, but I see the future is great in Finnish society. I was also unaware. On 24th, I had attended your conference. So I saw something which is a very different kind of approach towards sanitation, health, and economy. As we know that health is wealth. So if we improve sanitation, indirectly we are improving the economy. So I expect that in India also, in Odisha particularly, basically the government should take the approach towards our project. So it will be very easy for us to indirectly link all economy, health, and sanitation, and it will be a great future. Hello, sir.
Thank you.
Yes.
Thank you, Dr. Avinish. Yes, Jazz, please.
Awesome. Thank you so much. Now we'll move to our next panelist. We have Ms. Pamela Bundy, the country coordinator for Finnish Mondial Kenya. She's going to be talking to us today about finance. So Pamela, how is the Finnish Mondial Kenya team approaching investment of financial resources for sanitation at the household level?
Good afternoon and good evening, everyone. So thank you for the question. So for the case of Kenya, what we are doing is that we are looking at, as we approach households during sanitation marketing, we have a dialogue with them, getting to know what is their source of income and how often do they get it. But most importantly, encouraging them to save whatever little income they get, and also sensitizing them on the benefits of loans for sanitation. Now, why are we sensitizing them on the benefits of loans for sanitation? It's because when they invest whatever income they have at the household level upfront, it means they're left worse off than they were because they have other daily needs to cater for financially. So what we've been doing in Kenya is that we have partnered with various financial institutions that cut across from the bigger banks, microfinance institutions, but also SACCOs at the lower level. And we encourage the communities that we serve to join these SACCOs and microfinance institutions, become members and save whatever little income they have, so they can save towards sanitation, improving their toilets, and also in the process get a loan that they can pay over time, about an year, over a period of say 1 year to 2 years, depending on the repayment rates that will be required of them. But just going beyond that is that there are households that we come across that, let's say the most active member of the family is not in employment, especially considering that the rates in Kenya of youth employment are really high. So we work with these youth, get them into sanitation businesses, let's say like the construction of the toilets that we do. So we provide them with the technical training, also provide them with capital or link them to our partner financial institutions for capital for them to get into the sanitation businesses. And with the income they get, they can now support their families first in improving their own toilet, but also secondly, they're getting income now that will also support in catering for other household needs. Thank you.
Awesome, thanks so much, Pamela. And I just wanted to ask one other follow-up question. So you've been working on the digitization app for financial inclusion of sanitation. So how is this enhancing the uptake of sanitation at the household level?
Thank you for that question. So early this year, or is it late last year, we started working on a digitization app. And the background of this is that in the course of our work, we are also interacting with a lot of informal financing mechanisms on the grounds. These are merry-go-rounds of people doing table banking, and they rely a lot on books, on keeping records on books and the like. So we introduced this app. It's really light, and as long as, say, one member within a group has a smartphone, they can utilize this platform to record their savings and their internal loans that they're issuing to each other. But basically using the same platform to encourage them to save towards sanitation, because it's a platform that they can save at their own discretion and withdraw funds at their own discretion, but then of course within the norms and guidelines that they have agreed within the group and put them within this platform. But most importantly is here we are talking about financial inclusion. We don't want to leave them excluded or operating the way they have been within just that setup. We'd like them to access more funding, more capital. So with this particular application, we're able to link it to partner financial institutions who can then access their statements, who can see their track record, how they have been saving, how they've been getting loans. And with that, they're able to now use it also as a security and access financing to support sanitation for a start. Our interest is in sanitation for a start, but then in the longer term, the same can be used to facilitate their other financial needs. Thank you.
Thank you, Jazz and Pamela. Very good reflections there from Pamela on use of digital resources, just like we had from Dr. Avnish. Good examples again from India. I think we now turn it over to Angela from Uganda. Angela, if you can hear me, you know, uptake of sanitation by outsource is not a walk in the park. We all know that, all of us who are here. So if you could take a few minutes just to share with us how you are navigating that in Uganda. How are you lamping up uptake of sanitation by outsource in Uganda? What are the tricks?
Thank you so much, Dr. George. My name is Comfort Hajra Mukasa. I work for AMREF Health Africa in Uganda, supporting the WASH program. Uptake to sanitation, like you've said, is not really a walk in the park, especially when at the back of our mind, we want sanitation access to contribute to universal health coverage. So what we do is to make sure, first of all, when we're working with communities, we are not looking at communities as beneficiaries, but we handle them as partners and meaningful partners who first of all have to make the contribution to invest for their sanitation facilities, but also they have to make the decision. First of all, determining why should I invest in sanitation when I'm already spending a lot of money, catastrophic expenses on out-of-pocket expenditures in health. And so what we do is, we make sure that we are riding on the spirit of Africa, of Ubuntu, I am because you are. And one thing that we do well is to pull the community health and sanitation problems, put them in a pool in a form of a cluster, so that my problem becomes my neighbor's problem. And so when they're raising funds to solve their sanitation problems, they're solving a community problem. So that also when we start harvesting the health benefits, we are harvesting benefits of a community. Another thing we do is in Uganda, we have people that we really believe in, the cultural leaders and religious leaders. And we are a very religious community. We believe in the Bible and the Quran. So what we do is to link with people's faith and belief. Like in Deuteronomy, there's a verse in the Bible that says, if you want the Lord God to come visit you, then make sure the Lord God will not step in your feces when he visits you at night. So working through religious leaders and cultural leaders, people that the communities believe in, to tell them the why and showing them how that will contribute to their own health and livelihood helps a lot in the buy-in. But also looking that we are looking at a business approach to sanitation. We make sure that we have a best fit product for everyone. So we're not talking about one size shoe for everyone. We come up with a variety of products that fits all classes of people and make sure we have best fit loan products for everyone. And in addition to that, we are well conversant of the fact that we have people of different physical abilities in these communities. These clusters come in very handy to make sure no one is being left behind but also when making sure that we're sharing with the community how this contributes to their health. And sometimes it's a cost analysis and analyzing cost of health in a year versus the cost of investing a safely managed sanitation facility, comparing that with the cost of building a temporary latrine and that continuous expenditure. As we speak now, we're working on a delivery model that will bring sanitation services closer to the communities, thus further reducing costs and further making sure that the money that is pooled in the community savings in the clusters instead goes to accessing health, because our target is to have universal health coverage where not even money is a limiting factor to universal health. I thank you.
Thank you, Angela. That's very insightful. But just a follow-up question, because we are talking businesses here, we are talking sustainable sanitation businesses. Again, from your experience in Uganda, if you can share with us the kind of actors that you bring into play for it to be successful, because I guess there are many actors that need to be involved here. If you can share that just a little bit with us.
Yeah, thank you very much. Yes, we're talking business, but we're talking, so in this business of sanitation, the consumer is actually this person that does not have a sanitation facility. So we're very aware that actually, if someone doesn't have a sanitation facility, there could be very many factors at play. Is it their culture? Is it money? Or is it, I don't know, the need of a sanitation facility? So we work with communities not as beneficiaries, but as partners who we ride on to invest. So as we're working with these communities, we appreciate their input right from the word go and make sure that they appreciate the aspect of sanitation in form of a business, but showing them the long-term cost benefit. Someone needs to know that if I invest so much money, at the end of the day, I'll save so much in the long run. That's the conviction to invest. And then also we work with the government, because we know in the sanitation business, not everyone is going to be able to invest even when they can afford. That's where government comes in a lot, because government has got like the Community-Driven Development Fund in Uganda that we tap into, but government also helps us a lot in regulating standards and making sure no one is left behind, but also aligning our strategies with our own strategy. So government, and in addition to that, we always want government to have evidence of data that sanitation is actually contributing to universal health coverage. So we are using a digital solution to collect data that we call Kobocolate. It uses ODK. So when we're working with the government and community on ground, we collect real-time data that goes onto the system for government to see where actually the problem is. So the more reds they see in an area, the more cause to go to that area and make things better, but together with them. And it's the teamwork, therefore, enables us to plan ahead together and forge a way forward. But also being a business, of course, we need the people that give us the business people that we work with. Now, instead of waiting for them to give us the business, we sit at a round table and involve them in, so first of all, the best fit product that we want, the products that we need and designs, but focusing a lot on cost reduction, because our focus is access. So when there's cost reduction, and for us to achieve that, we need to work with these businesses from the word go. And then last but not least, we work with the people that give us the money. This ranges from both informal financing mechanisms, and we also work, like for the informal, we have informal saving groups in villages. We don't ignore those, because those will attract a certain segment of people. Then we also work with the formal financing. At the end of the day, we want people to be able to access funding, but best fit loan products for everyone, making sure that people are not being exploited in the process as they access sanitation for universal health coverage. I thank you.
Thank you, Angela. Amazing work happening there in Uganda. And you made a strong point for data. Data is the current gold now. So I want to turn this over now to Joydeep, who has worked in the insurance industry for years. And Joydeep, if you can reflect on the value of data, the kind of data that our colleagues are collecting from all these countries, what kind of data and what scope of data should we collect for it to make sense to inform businesses, sanitation businesses, but also to make sense to insurance companies that would be interested to get into micro-insurance. As we discuss sanitation businesses, micro-insurance, and a link to universal health coverage.
Thanks, Dr. George. Yes, data is now talked of as the new oil for everything, anything and everything that we do. Well, first of all, anything in sanitation that we want to do, there's got two angles. One is to implement, and therefore, whether we use data to implement and influencers like insurance companies and lenders, and then also sustain, because this has to be sustained. It's a behavioral change. Well, there's so many people who are doing open defecation across the world, largely in the two continents, the continent of Africa and the subcontinent of India. And then if you look at the implications of poor sanitation, that has been quantified by the UNICEF study of 2018, which for India, it has an implied economic damage of 7.9%. So finally, anything that we do to make it sustainable, we have to see the financial impact, social impact, and human impact, and make sure that whatever we do has got a particular sustainability built into it. So as far as collection of data is concerned, well, at PwC, we do, in our entire sustainability practice, we have actually constructed an index, sanitation index. And for that, we had to collect data. We had to go around, we've done this across 72,000 households in one state and another 50,000 households in another state. And we've collected information which can be categorized into two buckets. One is a structural indicator. By structure, it means toilets, infrastructure for water, access to water, access to ventilation, etc. Then the other one is which can be called as behavioral indicators. Behavioral indicators will include things like hand wash frequency, hand wash after defecation, the feces disposal, waste disposal, toilets being used as a toilet or something else, cleaning frequency. These all make up these two indices. And we've done correlation of that, and we have achieved a 98% correlation coefficient between these and sanitation, actually what you would like to see. So once you have a measurability, then it is easier for people to measure the impact. So it's a health impact. About 7 years back, when I was the CEO of an insurance company, we had launched a product with Finnish, which had an actual calculation based on spread of infectious diseases in India, as well as how can these habits of toilet being inside the house, used regularly, hand wash being done, how can it reduce the incidence of infectious diseases? Well, it turned out that we could afford to give out 17% discount of premium to people, or rather, in the renewal premium, to people who actually show behavioral sanitation positive characteristics, which meant there was 17% impact in the healthcare costs anticipated through actual analysis. So it is not difficult. It's just that it takes time to build this data, figure out false positives, and understand how all these behavioral data and the structural data will add to incentives. And we all know that to change behavior, make people adopt good practices, you need both. You need a bit of, you can have conformations done through, let's say, strictures, norms, pushed down. Well, that's a stick, but the stick, human ingenuity finds a way. So you need to have carrots. So I do believe that offering payer benefits, which means, let's say, insurance benefits, which will be bigger or lesser premium to people who show, or the households which show better sanitation behavior, as well as having a lesser onerous loan facilities, either in qualification for loan or even in payment backs like EMIs and interest rates to places which are showing positive sanitation behavior will go a long way. The UNICEF study shows an implication of poor sanitation harming health, therefore lowering productivity, which is 7.9% of the economy, which is a huge figure. So if we start really integrating financial inclusion, sanitation, health together, I think the convergence will work beautifully. And I think that's the way you can get this data in and analyze and make it do what you want to do.
Thank you, Joydeep. That's very, very useful, very important. And I see a clear connection between the various pieces. But I think even very importantly is the fact that already our teams are using tools that can be used that are already collecting data. So it's getting deeper and asking what type of data, when, how, and how do we analyze it for it to make sense? And how do we push our case from that data to insurance companies who would like to be part and parcel of this kind of initiative?
So the telemarketing initiative, which you just saw, which was presented, I think that can also keep collecting the data. So see, in any case, health data is sensitive and we have to be sensitive about data privacy. But then instead of individual data, look at community-wise data, look at behavioral analytics of data, looking at aggregation of data and finding patterns. I think that will also add on and show correlations over time. And if that can be shown to insurance companies and reinsurance companies, you'll find a lot of products coming through, which will have incentivization. The first telemedicine-based product has already been launched in India, which is called telemedicine as a claim. So which we also are a part in designing and helping that, where instead of a sum of money to be paid to the hospital, a telemedicine-based doctor consultation is the claim, which means in a way, it's like cashless doctor consultation. And in COVID times, that has really worked well. I think the entire telemedicine as a means, as a channel of delivering medical service has accelerated during the COVID times. And in its wake, all this, the data collection has become far, far more organized because this is done by larger institutions. So I think we have to keep doing this, keep collecting data for health data and keep collecting sanitation data and trying to correlate and looking for patterns. The 17%, which was possible in 2013, probably in 2022, it would be, one can have a better handle and can parse the data to actually differentiate between, make finer distinctions about different portions and different, different behaviors and different illnesses which are prevalent. India, Africa, these are very large tropical places and infectious diseases are prevalent, especially in the wet areas or wet monsoon times. But it is not the same everywhere. It's different. And I think that difference will get appreciated with data and finer products can be launched. But the financial inclusion piece cannot be ignored. I think that's an institutional support, not only from insurance, but from lenders, so that finally the village economy, the rural economy, overall finds it useful to push this business down. So while the carrot will be there, the stick will come from the community itself. The community will self-correct. I think that's the way to move ahead and make it sustainable.
Yeah, very good. And of course, come up also with the means that communities can use to do some basic analysis of the data so that it becomes a push also from there. That's really, really powerful. Thank you. Thank you, Joydeep. So I want to check with Carolina whether before I hand over to Jazz, whether we have the graphic that was captured on Monday, just to see whether it also reflects some of the thoughts that are coming to the floor today.
We do.
Oh, wonderful, wonderful.
Here we are. And I also have a question from the audience, Dr. George, if you want to.
Okay, I think Jazz will take that. Let's see what was captured here on Monday. Can a business approach link sanitation and curative healthcare? I think, yeah, I see lots of stuff here. Where are we now? Where do we go? Sanitation hygiene, I think, captures some of the bits that Joydeep was also reflecting on behaviors, all that. Technical assistance, also some bit of work that needs to be done with our government colleagues, private sector, supporting them. Okay, quickly, Kenya loses $324 million per year, or because of sanitation. Again, the link between health and the economy. These are huge loss to the economy every year. You can imagine what this would do in terms of increasing access to other social services, education, water, and such. But I see a point here around trust. I don't know what we mean by trust. And Joydeep, I might ask you to reflect on that a little bit. I think trust is very important for the providers, for the entrepreneurs, for the financiers, for communities, I guess. So financial inclusion, again, tricky there. I mean, important. Consultation, very key. I think it's about ensuring that you carry everybody on board in all these things that we are discussing here. But trust capital, Joydeep. Why trust is why is trust so important, and where and to who?
So societies and companies, and I will not, for the purpose of this discussion, I will consider both as large large institutions, societies are institutions by themselves, are today suffering from lack of trust. And we can have a 1-hour discussion on that. Trust is something that will make people adopt to behaviors that are being asked for, to change their own behavior. But there is always a lack of trust between institutions and individuals, because individuals are suspicious of the final motive of the institution, that whether it is self-serving, whether it's an insurance company or the society, the community itself, or if it's a lender. So I think the trust, one can't build trust overnight. Trust will happen over time with fulfillment of promises, with the kind of sustainability that is shown in the interest in the community. However, there has to be some action plan, and I firmly believe in execution. So if you look at it, trust is built through 2 big pillars. One is transparency. People should understand how things are going and what are the how things will work. And the other is predictability, which means if I should know that if I do this, if I fill this form, so and so such thing will happen. So for example, if I give a check for clearance to be in a bank, I know the check will go through from my account, money will go into your account, right? And in a particular time across the world, banks amongst financial institutions enjoy the maximum trust because they deal with transfer of money, and that happens unerringly. Similarly, be it insurance or be it change of behavior, there has to be platforms. So let's take one simple case of insurance claims. Now, if there has to be a standard platform for such kind of insurance given to people who are a low income, where there's a lot of, they are putting a lot of faith into this when they're putting that money, saying this, I will get some benefit in terms of my need. The system should be similar. It should be easy to understand, very simple. It should be transparent that if I filled in this or given my bills, then what is going to happen? Secondly, it should be absolutely predictable. If it's 48 hours or 72 hours, or even if it's 2 weeks, doesn't matter. Whatever is promised has to be delivered unerringly. And for that, it is important that instead of having individual companies, individual people decide the customer service, governments, institutions, regulators across the world for such micro health insurance need to develop a platform, just like the bank check clearance platform. It's not banks that do it. There's a platform which is run, right? There's a clearing platform. So like stock exchanges provide that for stocks. Otherwise, you and I will be constantly chasing each other for a stock delivery and money. So that's how, trust has to be systemically built, and then behaviorally, as in with a commitment to this to the community, it has to be finally realized over a period of time. And without that, it is not going to be sustainable. That's why our own motto of PwC globally for us to exist, and we look at it this way, that building trust and ensuring sustainable outcomes. Now, these words are not likely used. They are used because these are what businesses and society stand on. If this is so fundamental to society, so fundamental to business, commerce, GDP, life, health, and everything, I think one needs to think in these lines of implementation.
Very so, Jody. Trust has to be at the center of what you do, and we have to build this systemically. And it's so useful to what you're discussing today. I want to check whether Jazz, if you can hear me.
Yes. Yep. I'm here.
I want to hand over the mic to you now.
All right. Yeah. Thank you so much for that. I think that was super insightful and really great to capture it all in a visual. Thank you so much, Joydeep, for taking us through some of these connection points. Really appreciate that. And I know that we're sort of nearing the end of our session time. And I wanted to first make some space. Carolina, was there a question that we had outstanding that we should address?
Yes, just thank you. Yeah, we have a couple of questions. I think these are directed to Hajra and Pamela, specifically on the results of their project. So I will read them quickly. One is asking examples of in the country where there has been dialogue with national health insurance schemes to discuss, for example, reducing fees if a household has a safely managed toilet. The other one has to do with how, if you have been measuring how much healthcare expenditure, time, and lost income is saved after investment in a toilet and hand washing station.
And that's for, you said, Pamela?
Let's focus on the country. So I probably think Hajra and Pamela will be.
Perfect.
Could you ask your question again?
Yeah, Hajra. There's two questions. One, if there's any examples from any country where there has been dialogue between the national health insurance schemes to discuss reduced fees, for example, if a household has a safely managed toilet. The other one is another question, is how these programs are measuring how much healthcare expenditure, time, and lost income is saved after investment in a toilet and hand washing station.
I'll go first. Thank you for the questions. I'll start with the first one. If we've had dialogues about national insurance, not yet, because even my country as a country is yet to come up with a national insurance plan. We don't have one yet, but there's discussion in Parliament to come up with one. So the only form of insurance currently in Uganda is private insurance. When it comes to measuring cost reduction, yes, when we collect our data using Kobo Collect, so what we do when we pick, we even get specific coordinates of where the person is and stuff like that. So when we collect this data, we also track health indicators. Like for instance, diarrhea disease incidences are associated with diseases. We also ask the person, like when you're doing the survey, how much money they spend on health. So then we go back and together with the district health team and still assess, because some of these cases will not reach the healthcare facility, but for those that reach, we can track them through the health information management system. For those that do not reach, that's where our data collection system really helps us. For those that don't go to healthcare facilities to seek care, but go for the off-the-counter medication, still spending money, we're able to still track them when we see the indicators changing from red to green, and then ask them how they did it and what their experiences are. And people are always willing to share as a way of motivating other community members to actually invest. There's a case that we ran at one time when a woman told us she thought she had been bewitched because her children would always fall sick. So when she believed in investing in sanitation as a means of eradicating disease and reducing her expenses, her testimony came in very handy to encourage other people to invest in sanitation as a way of reducing expenses. So yes, we do track that, but as for insurance, we're yet to get there even as a country. Thank you.
Great, thank you so much for that. And I think, Pamela, did you have anything that you wanted to share on those questions as well?
Just briefly to mention that we're in the early stages of exploring how we can link sanitation to the National Hospital Insurance Fund, because over the last couple of years, there's been a drive in the country to ensure that every Kenyan enrolls to this hospital fund. And for us as Finnish, we feel that it will be interesting to get the linkage between our sanitation and the National Hospital Insurance Fund, but I must say it's still work in progress. Thank you.
Thank you so much, Pamela and Jar. Really appreciate it. Yeah, and I think we're going to move into the last bit of our program for today. Thank you all so much for joining us. This is just the start of a conversation. I know there's going to be some follow-up and some continued opportunities to engage on this topic. Sort of as we wrap, I know we're still very actively sitting in an unprecedented time related to health, the economy, and there's a lot of uncertainty and there's a lot of hardship that's happening. But I think this conversation and all of these intersections of the future of health and the future of sanitation really brings me a lot of hope. And I think kind of as Dr. George highlighted at the beginning, the future of kind of the future generations, right? As we're talking about, the people, the pipeline of creative innovators and entrepreneurs that are going to help kind of realize some of these case studies and these technologies and these opportunities in ways that we haven't yet seen. There's so much to be excited about at this intersection of business, health, and sanitation. I think, Dr. George, did you have any sort of closing words before we close out our session for today?
Very briefly, Jazz, I think this has been really exciting listening to colleagues here, but also the questions that are coming from our colleagues who are participating in this session. But I think two or 3 points. One is that no doubt at all in terms of that sanitation makes a business case, and that sanitation presents a huge opportunity for us to create livelihoods and businesses for young people across Africa, across Asia. I think that's powerfully come out of the discussion. And the link between sanitation and the universal health coverage and gender has come out very clearly. And of course, the case for financial inclusion and the link with microinsurance that has been so well articulated in our discussion. And the fact that now technologies are available to accelerate all these things that we could not have done 5-10 years ago. And we've been enthused to listen to the telemedicine link in India, the digital tools that our colleagues in Kenya are using to ramp up financial inclusion, but also to create awareness. That's powerful, and I think we can do much more. And the fact that then you can use these digital tools to now do what, again, we are saying is the current gold, to generate data that gives you an idea, an understanding of customer needs, customer preferences, but also do serious market intelligence and understand what you need to do for you to succeed in sanitation business. So simply connecting the dots, seeing the patterns, and also creating behavior change. And finally, I think very powerfully what we are all agreed on is that at the middle of all this conversation, at the middle of all these pieces that are moving, is building systemic trust. I think that's the most important capital that we cannot ignore, even as we think of sanitation, businesses, entrepreneurs, governments, customers, households, and creating employment opportunities for millions of young people who are looking for them. I think that has been a powerful conversation. Just so excited to have been part of this. And over to you.
Yes, thank you so much. What a great note to end on. Thank you all again for joining us, and be sure to stay in touch as we continue this conversation. I'm really excited to have had this opportunity, and yeah, looking forward to the continued conversation. Thank you so much, everyone.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
Good afternoon, good evening. Bye-bye.
Thank you, bye.
Bye.
Namaste to all and one.
Thank you.